Uh, good afternoon, everyone. So we are going to start our IC on cataract surgery in already operated eye, previously operated eye. So may I request my co-chairperson, Dr. Amit Raj, also to be here. So, you know that phaco surgery nowadays is not very difficult for most of us, but there are situations, there are conditions where the eye has undergone some kind of surgery previously, and these eyes are not so easy to operate because it requires different sets of preoperative workup, intraoperative care, and postoperative care also, and modifications in the technique. So we are going to discuss on all these subjects. May I request my first co-instructor, Dr. Rajan Anand, to talk on tackling cataract in a previously operated eye. This eye who has undergone open glove injury and has been operated earlier.
Good afternoon, everyone. Thank you, Dr. Subhash, for providing this opportunity. We had this instruction course in the last virtual conference also, and the viewers' response was good, and that is why Dr. Subhash has been given a different chance. With some modifications, some additions, we are presenting it again. My topic is cataract surgery after an open globe injury. And this is a very common situation that we come across. There are no financial disclosures to be made. 65 to 80% cases of traumatic cataracts are due to open globe injury, and it is commonest among children and young adults. The globe injury mostly are in the areas of cornea, limbus or sclera. Associated anterior segment injuries or posterior segment injuries may be present. One important thing is when to take up the cataract surgery. Either primary, that is while you are doing the repair, or do the repair and take up cataract surgery later. Later is the better, is a general concept, because the surgery is easier, the cornea will be clearer, tissue will be less reactive, IOL calculations will be more accurate, better chance of in the bag placement. Although there is a contrarian view, there is a study in Tehran in 30 cases, and they found no difference in the BCVA in primary and secondary procedures. Pre-operative workup is important because there is not just ordinary cataract. Documentation, there may be medical legal issues. The visual prognosis should be explained and written. Extent of open globe injury prior to management of the lens injuries. The presence of lens dislocation, capsular tear. So whatever pathology has occurred, whatever damages have occurred, you should be aware of it before taking up the case. An X-ray, CT or USG if you suspect an intraocular foreign body. Determining the type, whether it's cortical, nuclear or a capsular, and the extent, a focal or a total cataract, has to be seen first. Intraocular inflammation, there might be iritis, posterior segment trauma, lens-induced glaucoma or uveitis. Take care of these first. And a high IOP is very common. PAS, pupillary block, angle recession, these things should be included in the preoperative workup. You should be sure of what you are going to deal with. Biometry and IOL selection again is a bit challenging. If this eye is so bad damaged, the cornea is so bad that you can't get a K reading, then we have to depend on the contralateral eye. An acrylic single piece or a multi-piece foldable in the bag would be preferred, but you may have to implant it in the sulcus. When sulcus fixation is desired, obviously a 3-piece lens or a single piece PMMA. AC lens may or may not in an elderly patient with good iris support, no evidence of glaucoma, and AC is free of vitreous, then you may think of an AC lens or an SFIOL if you are competent enough and the tissue allows it. No AC IOLs in children, please. The first thing you'll do is to manage the capsule, and it may be torn. If it is intact, you can do a CCC, avoiding zonular stress. If it is ruptured, cut away the tags and fashion an opening as close to a CCC that you can make. Remember, old capsular openings will have fibrosed margins. Remove or break the synechia if they are present. If there is a 30 to 90 degree of zonal dialysis, use a CTR. If more, there are other options like the capsule fixation rings, the Sioni rings, segments, and glued hooks designed by Dr. Susan Jacob. If there's an extensive subluxation, you might have to do an ICC with a secondary IOL. If there is vitreous in AC, first do an appropriate vitrectomy. Now, these are some traumatic cataract cases. You can see that the capsule is cut and fibrosed in this picture. This is almost a total subluxation. You can just see the top of the lens here. I doubt if you can repose it, and maybe you'll have to do an ICC in this case. After you have managed the capsule, now the nucleus management. Generally, these are young patients, and so the lens matter is soft and can be aspirated by a bimanual or a coaxial IA or Simcoe. If formed nucleus is present in adults, do a slow phaco procedure. Any difficult situation in cataract surgery, you'll hear that word, do a slow phaco. So what is a slow phaco? You don't give more time to it, you reduce your parameters. If corneal opacity is hampering the view or the nucleus is hard, you may even consider SICS. And if corneal scarring is gross, you may think of a keratoplasty and a cataract surgery together if you have a corneal surgeon or if you do a keratoplasty yourself. प्रीव्यू में था मिनिमाइज कीजिए
इनेबल तो कर दिया मैंने
क्या हुआ
इनेबल तो कर दिया फुल थ्रेड
You can see a capsular opening and there is a synechia. This is a coaxial IA being used, and this is Dr. Subhash's case. He's just aspirating it carefully. There might be vitreous anywhere. This injury is old, and so you can see that the capsular margin is quite fibrosed, and he is able to implant a single piece acrylic in the bag. Now he is using a vitrector. That is the point where he suspects that there is some vitreous. So the lens is placed nicely, and this young gentleman is going to get a decent vision. This injury is a bit bad than the previous one. This synechia, there might be zonal dialysis that side. He is trying to fashion a rhexis. The capsule is fibrous, thick, couldn't do it with the needle, opened it with the MVR and then using a rhexis. Careful towards the site of injury. Again with the coaxial IA, aspirating the cortex. And a multi-piece lens in this case. Try not to fiddle more in the area where you suspect the injury is more, because you don't know what's underneath. And so even this case has been managed nicely. This was a case repaired, corneal injury repaired about 3 months back. This part, the sutures are still there. So I give 2 nicks and try to fashion a rhexis. But towards the injured capsule, it's not tearing off, so I have to use a varnish to cut it off. And this is with the phaco probe, but in the IA mode. So you don't have to use phaco power. Soft cataracts usually get aspirated. A bit of nudging with the dialer. And that small piece left, now going down is risky, so I remove that with the bimanual. And so this case has a decent rhexis now, but I still implant a 3-piece lens. There is a young patient. And this was third post-op day of the same case. Is as good as it can be. Now this is a 8-9-year-old girl. You can see the tear here. It's just a 3-day-old injury. It's still gaping, and there's a fluffy cortex underneath it. So in this case, I had planned to do the repair and the cataract removal together. Unfortunately, the patient did not turn up for surgery, but I think she must have got it done somewhere else. In such a situation, I would have done a combined repair and cataract, because the fluffy cortex can't wait for long, and this cornea has to be repaired first. The prognostic factors, you've done the surgery, okay. The prognostic factors depend on what was the initial visual acuity. An open globe have better post-op vision than a closed globe injury, because in a closed globe injury, the retina might have been compromised. Location of the wound, and there's an ocular trauma score, which gives a good predictability of the post-op vision depending on these factors. Follow-up has to be long, because these are young patients, and it's not a routine cataract. You cannot predict the behavior. There's a risk of infection, glaucoma, developing amblyopia, PCO, posterior segment complications, and of course medical legal, which doesn't leave us. So the summary is, there can be a variety of presentation. Decision making is important as your skill. Management of traumatic cataract is challenging. Outcome depends on collateral injuries, but usual vision can be restored. Thank you, and I acknowledge Dr. Subhash Prasad and Dr. Nazneen for some material they have provided to me. Thank you very much.
Thank you, Dr. Rajan Anand. Rajan Anand is actually a very senior ophthalmologist and is very good orator and has been the chairman scientific committee of Bihar Ophthalmological Society. So any question from audience regarding this, managing these cases of trauma who have undergone repair, primary repair, or going to have for secondary repair? One thing is very important, that no two cases are similar. In any case of trauma, or the two cases are different, they have to be approached differently. And regarding post-op management, all of these patients can develop some type of complication like glaucoma, posterior synechia, so they have to be followed very regularly. And apart from that, amblyopia therapy is must in these patients, because all are children. So anything else?
Dr. Subhash, when there are no questions, there are just two situations. Either I couldn't deliver what I wanted to say, or it is so common that everyone knows about it.
My question is, in case of the perforation of the cornea with the anterior capsule damage, you go for the corneal repair and the for cataract operation. What is the mode of power, IOL power calculation? Is it better to other eye or standard power?
Yes, because in this eye the cornea is scarred. You might not get a good keratometry. You can take the K reading of the other eye. If you can get an axial length of this eye, fine, or else you have to depend on the axial length of the other eye also.
Thank you.
What are some of the primary investigations you will do, you must do before taking up these injury cases for surgery?
Apart from your routine cataract workup, X-ray or a CT
In connection with the trauma.
in connection with the trauma, an X-ray or a CT to see for a foreign body, and maybe an OCT to see if there's vitreous hemorrhage or not, or posterior segment complications. I mean, associated injuries could be in the posterior segment or in the orbit.
One of the most important thing in these kind of cases is the medico-legal issue. They come with the expectation कि चोट लग गया, रोशनी चला गया, डॉक्टर साहब ऑपरेशन कर देंगे, कल मेरा रोशनी आ जाएगा, which doesn't really happen. So you have to have that consent form very, very carefully filled so that you don't fall into trouble.
I would suggest if you suspect that this patient is going to create problems, have a video recording of your counseling.
So what is the protocol of end-of management you do in cases of trauma patients?
Trauma end of after the surgery or?
No, sir. Whenever a trauma happens, either the soil particles can also predispose to end-off in the patient. So what are the precautions you take before that?
Precautions or management of end of? What are you asking? Precautions. Precaution is if you are dealing the injury first. I mean, if the patient has come to you with the injury, and this is a situation when there was an injury, it has been repaired, and he has come for a cataract surgery. So if you are dealing with an injury as such, then obviously the antisepsis, cleaning the wound before suturing, if you can give an intracameral, follow it up for the first 3 days, that is the time when end-off will occur. And if it occurs, then manage the end-off with intravitreal injections, 1 or 2, and then vitrectomy. The treatment of endophthalmitis will be the same.
All open globe injury must be given antibiotic, systemic antibiotic also. And like in our cataract surgery nowadays, we used moxifloxacin, so we can use intracamerally moxifloxacin in all cases. And we have to be very observant, vigilant for initial few days. That is most important thing.
I
So-
think you can be aggressive. If you said soil, it could be anything, and the things can get worse very fast. So you can close the globe and take a VR opinion and go ahead and straight do a vitrectomy at that point of time if that is warranted.
And a daily follow-up if you are dealing with the injury.
Thank you, Dr. Rajan. So we'll move to the next speaker. And yeah, you want to say?
Just one more comment. As there is chances of injury from the organic matter, so one should be vigilant for a long period. There may be chances of fungal end-off or P. acne end-off latter. Thank you.
So there is change in sequence. Dr. Amit Raj, who is the professor and head of the Department of Ophthalmology, AIIMS Patna, has to leave for another session. So Dr. Amit Raj will come for his presentation on managing cataract in post-intravitreal injection patients.
Last one. Yes, this one.
Nowadays, lot of intravitreal injections of anti-VEGFs are being given right from periphery to big hospitals, and these patients can have cataract also because of that. So he is going to discuss that.
At the outset, I am thankful to Chief Instructor of this session, Dr. Subhas sir, for making me part of this instruction course. So, coming to the topic, as intravitreal injection is, especially anti-VEGF, is being used frequently as in different types of retinal vascular lesions. There is price initially patient pays, and if complication occurs, then again he has to pay that price second time, but again it gives more stress to the surgeon. So this intravitreal injection has surpassed the cataract surgery in US. So you imagine the number of injection is being given, and it's in different study its incidence is around 0.44 to 0.6%. So what complication can occur with any intravitreal injection? Right from simple subconjunctival hemorrhage at the site of injection to raised IOP, to a dreaded vitreous hemorrhage, retinal detachment, endophthalmitis, and CRO. But cataract is not very frequently reported, so I searched the literature, and one of the study done by Moorfield Eye Hospital in 12 to 15, and they have included around 63,000 cases of cataract surgery, out of which there was 1.64% intravitreal injection was given, and PCR occurred in 1.04%. But after logistic regression, it was found that there was increased risk of PCR in cases where intravitreal injection was given. Another study, in this study again complication rate of PCR was studied. So out of 10,327 cataract surgery, there was 2.6% PCR in patient who has received anti-VEGF, while only 0.5% PCR occurred in rest of the cases. So what is the main reason of this cataract formation? There may be faulty technique. The patient may be very uncooperative during injection, maybe due to pain, or patient is just not cooperative for the procedure. There may be jonular trauma, either there may be direct jonular trauma, or due to deformation of the globe there may be jonular trauma. There may be direct, if you are not going to the proper site of injection, then one can directly injure the posterior capsule. And again, in type of injection, mostly anti-VEGF is being given, but when you are using IVTA, intravitreal triamcinolone, or dexamethasone, chances of cataract formation is high. So what precaution one should take while giving anti-VEGF? First, one should know the phakic status, whether patient is phakic, pseudophakic, or aphakic. Then question comes, what is the preferred site of injection? One should go for 4 millimeter away from the limbus in phakic. In pseudophakic and aphakic, one should go for 3 to 3.5 millimeter. Inferotemporal quadrant is the preferred site, but one can go to a superior temporal, and lastly one can should go for superior nasal, but one should avoid inferior nasal quadrant. Regarding the gauge of needle, ideally higher the gauge, lesser will be the pain, lesser is the chances. And again, length of the needle is important, 0.5 inch to 0.62 inch is should be the length of the needle, and direction should be of the needle should be towards the center of the globe, and speed of injection should be moderately slow, otherwise there is chances of detachment of the needle from the main injection, and it can again injure the posterior capsule. So there is no alternative of thorough history in these cases like any other cases, but there are some clinical cues. When you go for slit lamp examination, there may be needle track injury, and one can suspect then there will be chances of PC defect. But in mature cases, when cataract is so much there, you will not be able to see the posterior capsule. So one can see the wrinkling on the surface of the capsule. In these cases, when there is history of anti-VEGF, there is some clinical clue, one should always take help from the different modalities like UVM, B-scan, anterior segment OCT, and Simplug imaging. So one can clearly see the defect in the PC. So in a study, it was found that which instrument it gives better insight into the defect of the posterior capsule. So it was found that UBM has more sensitivity and specificity compared to anti-segment OCT and sign plug imaging. Again, accuracy rate is also high in with UVM. So, when you have come across a case of cataract who had chances of PCR, pre-existing PCR, so how you will manage? So, why it is important? Because there is chances of nucleus drop when you are not taking precaution. So, VR setup should be ready for that, and these cases should be done under perivalvular anesthesia. Another most important thing is one should counsel the patient and attendant about the risk in these cases. So, these cases should be managed like posterior polar cataract. So, like posterior polar cataract, one should avoid hydrodissection. Parameter should be low. Bottle height should be low. So, after removal of the initial central part of the nucleus, one can see at this stage PCR was detected. So, before removing the aspiration cannula, one should form the anterior chamber so that PCR should not increase, and it is individual choice. One can go from limbal route for anterior vitrectomy, and if you have access to trocar, and one can go through the posterior route. But in different study, it has been found that by posterior route, vitreous clearing is better compared to anterior route. Three-piece lens in these cases is desirable because and one can go for optic capture also for better stability, and after that tricoat is injected to see any vitreous tag, and again vitrectomy should be done. So, to summarize, large number of patients are benefiting from intravitreal injection. Adequate precautions should be taken while giving intravitreal injection. A small percent of them may end up with iatrogenic capsular damage and traumatic cataract. Preoperative use of imaging modality can be very useful to detect or confirm PC defect. Meticulous pre-op evaluation and proper surgical approach enhances surgical result in these cases. Thank you very much for patient hearing.
Thank you, Dr. Amit Raj. Any
Any-
question from
any
the
question
audience?
related to this?
The one comment very important, he has said that you have to have a very high index of suspicion in any patients who come with rapid progression or rapid onset of cataract and who have undergone intravitreal injections. So generally what happens that these patients who are undergoing treatment for the vascular disorders, they have very poor vision or very less vision. So they may not report you so early, but whenever they come and they say that I am having further decrease in vision after the injection, then you suspect cataract and you dilate it properly and try to see any track of needle injury. If it is not, then if the cataract is very progressing very fast or it's total, then other modalities really help. And again, he well said that managing these cases like posterior polar cataract is very important.
Uncontrolled long-standing diabetes with a history of DME, with a history of having this anti-VEGF injection, preoperatively would you prepare any differently from the regular cases which were not so much long-standing diabetes?
Yes, if there is a clue, especially in other eye, there is a CSME, so one should go for at the time of after completion of surgery, one can go for intravital injection, or you may go for 1 week before the surgery. But problem is that you have to take patient for 2 times in the OR. So better to give simultaneous injection at the time of surgery.
At the time.
After completion of cataract, one can give injection of
On the same table.
whatever ranibizumab eccentrics like.
Suppose we are planning for first intravital and then cataract surgery. So how many days should be there?
Ideally, one should give 1 week before for better effect, or one can give go for 1 month before. But in different study, it has been found that if you are giving simultaneous injection, effect is good.
After how much time should we suspect that this cataract is because of injection? See, today he has given injection after 1 week or 10
Yes,
days.
generally there is fast progression, but most of the cataract develops within 1 year. Within 1 year. Although whenever you are giving injection, one should examine after next day, 1 week, then after 1 month.
No, but if it is a faulty technique, it can just happen in a week or 10 days, whatever. If it is a faulty technique and it has really
It
touched
may develop, but generally within 1 year cataract.
But
develop.
no, but I would like to intervene here. The cataract can be because of the as such multiple injections are known to predispose for more
Yeah, but then
cataract,
how
but
many- how
but
much
that will not lead to such kind of cataract. If it is because of touch, then it will be almost immediate, and it may progress or may not progress. In some cases, it gets plucked because of the solid vitreous. Sometimes it gets plucked, so it doesn't progress. But in some cases where the injury has been bigger, like in Ojudex, I have seen 2-3 patients of Ojudex coming immediately at next day with huge, with you can say very progressive kind of cataract. So depends on the contact and needle, and also pre-existing cataract also. And if the patient's diabetes is not also well controlled, then these patients are landing with very rapid progression of cataract.
So how much
So
time
early.
should we wait? Today you have given Osudex and we detect the cataract in a week. So how much time should we wait to do the cataract surgery?
Cataract surgery, in my opinion, it should be done as early as possible because it's going to
Even if
progress
it is
very
few
fast.
days
Yeah.
before we-
I mean, if the cataract is very early, then you can very well see the posterior capsule margin and can manage it nicely. But if it has progressed too much, then there are more chances of complications, more chances of nucleus dropping into the vitreous. So it should be done as early as possible.
If it is diagnosed early, then naturally it is okay. But in longer standing cases, one advantage is that there is fibrosis of the posterior capsule. So it will not enlarge in longer standing cases, one of the advantage. But when you are diagnosed early, a patient has problem with cataract, so one should go for surgery.
Thank you, Dr. Amit. I will invite
you, sir.
next speaker now, who would be speaking on phaco in post-LASIK and RKI. We know that nowadays lot of these procedures are being done, and these actually creates a lot of challenges to not only for biometry but also intraoperative also. So Dr. Sujit Misra, who has been consultant at Arvinda Eye Hospital, is running his own clinic in Patna, will be speaking on this very important topic, the phaco in post-LASIK and RKIs. We'll request you to be on time.
Thank you very much, Dr. Subhash Prasad, for making me part of this important instruction course. I'll be talking on phaco in post-LASIK and RK. More than 40 million patients have undergone refractive surgery in last 20-25 years and form a sizable proportion of the population visiting an ophthalmologist. Patients that have undergone refractive surgery are highly motivated for glass-free vision, and it is very important to sensitize them about the inaccuracies post-cataract surgery you are going to face in such cases. Challenges are multifold, which can be grouped into preoperative, intraoperative, and postoperative. Coming to preoperative challenges, biometry a major challenge. I'll be coming to it. Other than that, these patients, you have to understand that when they underwent LASIK surgery, it was simultaneous bilateral. But when you are taking up For cataract, it will be one at a time. So you have to make them understand that they are going to get monovision sort of thing unless both eyes are at rest. Then these are being high myopic eyes, the usual complications associated with any high myopic eyes, you have to keep that in mind. You have to have an eye for glaucoma, and proper measurement technique should be adopted to get the baseline IOP, and in follow-ups you have to have an eye on the change in intraocular pressure. Status of jonules should be assessed properly, dry eye evaluation should be there, and regarding IL selection, it is advisable, even the IL power comes 0, you should put the IL because it acts as a barrier and it prevents endophthalmodonesis. So it is better to put the IL rather than leaving it as such. Minus power lenses may not be readily available in your stock, so when you are taking up these cases, make sure that you have asked for the significant time before lens arrives in your rack. And then IL with negative spherical aberration like Technis or Acrisof IQ would correct spherical aberration induced by myopic LASIK. Multifocal ILs, it's about pushing the boundaries with all the new armamentariums. So you should never say no, and I will never be very much aggressive also. It's all about keep watching what happens, because a lot of things are there. Coming to biometry, as such, axial length, nothing has changed. The main area of concern is keratometry and IL formula and ELP related. We all know that keratometry is based on certain assumptions, I won't go into the details, which is grossly violated in refractive surgery cases. So it's not that we cannot measure corneal power, but the power that we are getting is not accurate. Another thing is effective lens position. The effective lens position is tagged to the corneal curvature, and when you have changed the corneal curvature, now the new calculation will show some other ELP. But in reality, we have not altered the distance between cornea and crystalline lens, anterior lens capsule. So this gives a fallacious ELP estimation. So this is the basis, this is the thought process behind Aramberi double K method. So what is done there? Preoperative K value is taken to calculate the ELP, and the postoperative K power is put into Vergenon's formula to get the IL power. So this is the thought process behind Aramberi double K method. So we are left with two tasks. One is either measure true corneal power or make necessary adjustments into it to get the corneal power, and second is IL formula selection that takes care of ELP. N number of formulae are available, and whenever number of options are more, it is obvious that accuracy is less. That is why you have more options. So broadly going into it, if you look at some different approaches to get the corneal power, then we have clinical history method, hard contact lens method, topography based post-LASIK adjustment keratometry, central ring topography method, and net corneal power measurement. So clinical history method, what we are doing, just to give you an insight, suppose the K reading, original K reading was 44, the original refraction was -8 diopter. Now post LASIK surgery, the power patient is having without cataract is -1. So how much we corrected? 7. So this is a basic approach that from 44 you subtract that 7 diopter, so you are left with 37. These are the simple method and how we evolve with time. You know, another approach is topography based corneal power you have calculated, and various correction factors are added to it to get a corrected value. Koch and Wang, they recommended a correction factor of 6.1, and Sharma's formula, they gave the correction factor of 6.8. Central ring topography method, 1, 2, and 3 mm area topography method K value is taken and averaged. So these are the approximations. Then a net corneal power measurement, where anterior and posterior corneal surface is directly measured by methods like slit scanning tomography, Scheimpflug photography, or optical coherence tomography. These are used in post-laser vision correction cataract and may not be suitable for post-RK cases. Then there are subset of patients where you have irregular astigmatism, epithelial ingrowth, DLK, and keratoconus and ectasias. So you should be very clear in counseling the patients that these are the subset where you should be prepared for suboptimum results. What will you give if you can't measure properly? So the counseling part is very important in these cases. Coming to IOL power formula selection, what is the ideal situation? You have preoperative value of K reading, post-operative value of K reading, and pre and post-op refraction. All subsets of data you have, that is the ideal situation, but mix and match of these situations will be there in your hand. So various options for formula selection is methods relying entirely on historical data, methods using historical data and current corneal measurements, and methods using only current measurements. So just for prototype, it's a lengthy topic, but just for prototypes, I will discuss few to give you insight. What happens in corneal bypass method? Here, preoperative K value we have taken, axial length we have taken. Normally, what is the target? Postoperative refraction target, 0 we have put. Now here what we have done, suppose -5 diopter power was there. So postoperative target, how much we will put? -5. So we have bypassed everything. And whatever value is there, with current measurement, you add that value. So these are various approaches. When you don't have exact direct measurement, then these are the approaches we have been adopting all these years. Double K formula, I already mentioned to you. And the correction factor that is available, this is just to show you, these are the charts which are used to apply those correction factors into the various post-myopic and hyperopic refractive correction patients. So these charts are used to make those adjustments. Then Haig-Cell formula, this is the most widely used formula nowadays, which is available with IOL Master. So this again uses cornea bypass method. The formula applies a correction curve to the existing method. It's a set of data bank. This type of laser has been corrected, and this kind of curve is needed to make the adjustment in corneal power. So this is a relatively widely used formula, and it doesn't require pre-refractive surgery, keratometry, and treatment data. Accuracy may decrease if the eyes are on the edge of the normal distribution curve. And this is used for LVC, not post-RK cases. Then you have ASCRS website online calculator available. But if you look at I calculated for one patient, and if you look at the details, it doesn't give single value. You will have multiple options. So here also you are not getting one answer. So this is to again emphasize that we still have that one single answer. Now, post-RK cases, you have to understand that there is a phenomena called decay. Suppose you have corrected, post-op power is 0. That doesn't mean it will remain so. There is hyperopic shift. So for that, there is a general recommendation that if you have 4 to 6 RK incisions, add 1.5 diopter to the calculated power. If it is 8, add 2 diopters. More than 8 incisions, add 2.5 diopters. This is a gross suggestion to counter that hyperopic shift later on. Then coming to peri and intraoperative challenges, we all know with long eyes, challenges are there with block, and then intraoperative complications you should avoid with any high myopic eye PCR cases. And another important thing is the lens iris diaphragm retropulsion syndrome. So simply you have to do that. You have to lift the iris with instrument and direct the irrigation flow beneath it, so that in LIRDS, what pupil has dilated, stretched, it will come down to normal size. and avoid discomfort to the patient. American Academy Ophthalmology recommendation is optimum viscoelastic pressure head should be used. There should be minimum leakage from the wound so that anterior chamber flutter is minimum. These are either deep, AC, and then you have to reduce this. This is a post-RK case. A number of cuts are very high, so we have gone for, thanks to Dr. Subhash for this video. So scleral corneal incision will be better in these cases, and post-op results you can see. This is another case. It is always prudent to measure the clear corneal area where you will be making entry so that you don't enter into the RK cuts, and phaco is finished in a routine way. There was a problem with this case that there was wrong post-operative surprise was there. So explant was done in this case, and IL was cut with 1 hour and new lens was implanted. So post-operative, a combination of NSAID and steroid antibiotic is used. Possibility of steroid response should be kept in mind in these cases. Keeping the incidence of retinal detachment in mind in high myopes, dilated fundus examination should be done post-operatively, and later on annually. Residual refractive error should be addressed properly. NDA capsulotomy when needed should be done with low energy. Counseling for other eye surgery should be done to reduce the duration of anisometropia. Thank you very much.
Thank you, Dr. Sujit. That was really excellent presentation. Any questions from the audience? If there is no question, then I'll move to another next speaker, who is Dr. Alan Kumar Pashupati.
Thank you.
He is postgraduate of RP Center,
In
is
a-
a cornea expert. In the meantime, you can just. He has own hospital in Bangalore, now Shakti Netralaya. He is doing a lot of cornea work. So we would be talking on phaco in operated PKs and LKs.
Dr. Sujit, in a refractive surprise, do you suggest if the refractive surprise is more than a certain amount of diopters to put a piggyback IUL, or you would want to go and do an IUL exchange? What are the things you take into consideration before doing a piggyback or IUL exchange?
I would prefer to do piggyback IUL. In recent days, earlier, we didn't have a lot of options, or even if it was available, it was not so easily available. But with time, our lot of things we have, and it is easily available. So definitely I'll be going for piggyback. Only thing I will do is I will counsel my patient. I will wait for things to stabilize and then make a decision.
So it's better to wait for 3 months until everything gets stabilized. Then we can have the option. This surgery which he has shown was done quite long back, around 14-15 years back. At that time, we didn't have that much of options. Now even Care Group have come out with very good piggyback lenses that is quite cheap also and can be used in many patients. And that is actually hydrophilic with 4-point fixation. So that is very safe and very easy to implant and very good, excellent result. I have some patients who are actually doing very well even after 2 to 3 years. So that is very good option.
But if it is detected earlier, especially within 1 month, it is prudent to explant the IOL and implant proper power IOL, because if you are using piggyback IOL, chances of angle crowding is more if one is using
These are myopic eyes. We have to remember, first of all, these are myopic eyes, and whenever these are identified, we have to remember that there is a time for stability.
Yeah, we can move ahead. Alan.
Thank you, sir. At the outset, I would like to thank Dr. Subhash Prasad, sir, for giving me this opportunity to be part of the IC. I'll be talking about phacoemulsification or cataract surgery in operated keratoplasty eyes. We all know that cataract is more common among post-keratoplasty eyes, and the cause for this, number 1 is steroid use, number 2, intraoperative manipulation, and number 3, inflammation. There is more chance of inflammation in the immediate post-operative period. These are the 3 major causes for cataract, increased incidence of cataract in cataract surgery. What we are worried about in these cases is these kind of cataracts. If there is any touch to the capsule, immediately in the post-operative period, within a few days, there was a question raised about intravitreal injection, something like that. Within a few days, it can become intumescent like this, and we will land in trouble. So care should be taken even during the first surgery to do a proper surgery without touching any of the lens part. As we age, more chance of cataract. Similarly, the more the time duration after keratoplasty, more the chances of cataract, more the inflammation, more the chances of rejections in the post PK, there is more chance of cataract. Also, we should remember penetrating procedures have more chance of cataract than non-penetrating procedures. So dialc is much more safer, but we have seen cataract even in dialc patients earlier. What do we do with these cases? I'll be talking about the cataract surgery in this thing. Timing of cataract surgery, IOL power calculation, wound construction, corneal endothelial protection, and post-operative management. Now, IOL power calculation, there's one sentence I would like to remind. Most of us are using Barrett formula, but only thing what we have to decide is whether to use a toric lens or a monofocal plain lens. This is what we have to decide. That I have put up a slide. Now, when do we do this cataract surgery? If you see an intumescent cataract like this, threatening the angle, threatening to cause glaucoma or other problems, immediately it has to be taken up. And a beautiful thing was told initially. You can leave it aphakic and then correct it and then do a refraction and then put in the lens, because lens calculation is going to be very difficult in these cases. We can't normally use the other eye also for these cases. In case of intumescent cataract, however, the best time to take up these patients if it's a slowly developing cataract is minimum 6 months apart. We should have had same keratometry readings. That is, we should have removed all the sutures and the cornea should be stable at least over a period of 3 to 6 months minimum. 2 intervals. If the cornea is stable, 2 topography at 2 different intervals, then we can go ahead even with the advanced lenses. Remember this. In case that is not possible, it's always better to go with a monofocal lens or leave the patient aphakic and go for a secondary lens implantation. This is another thing what I was talking about. If the surface is regular, what do we mean by that? The central 3 to 5 millimeter zone in a topography should be regular. This is what we are talking about when we talk about regular corneas. If it is regular, we can go ahead with a single stage surgery. By single stage surgery, I mean a proper lens implantation also. It could be toric or one of the advanced lenses. When it is irregular, it's always best in the first stage surgery to correct that irregularity. Either we can go for a surface ablation, or if there are any sutures that are causing it, remove the sutures, wait for it, and then plan the surgery. By 2-stage surgery, what I mean is stabilize the surface and then go ahead with the surgery. 1-stage surgery, always which is a regular surface. As regards the lens, which one to choose, both of them are fairly doing well. Initially, we always said do not use any advanced lenses in post-PK patients, but now we are using toric lenses very freely. A few of us are using even multifocal or the AIOC lenses, but I have personally not used them. What I would prefer to use, if the surface is stable, if I can calculate the keratometry properly, be it with a topographer or whatever it is, if I can do that, then I'll go ahead with a toric lens. If the toricity is more, we are lucky to have even custom-made toric lenses available. IOCare is making those custom-made lenses up to 20 diopters. I saw a 20 diopters being used. I personally use 9 diopters of toricity. Or in case of doubt, in case it is irregular, then go ahead with a monofocal lens. This slide, deliberately I put it. I don't know how many of you can see this was actually an AIOC lens from a friend. But personally, I would like to avoid these lenses. But people are using it. That's why I wanted to show you. So whenever we start the surgery, remember that it should be a regular astigmatism, stable cornea, have a good endothelial count, and that last sentence, double-edged sword, have a proper consent obtained. Proper consent, that consent should have 3 different features. 1, dehiscence of the wound during the surgery. Number 2, graft failure. And number 3, graft rejection. These are 3 things that should definitely be there, and there should be a sentence saying there might be multiple procedures that should be required. These 3 things should be there in the consent form. As regards the incision, all of us are very comfortable with the corneal incision. Many of us are good with the scleral incision also, but when to use what? In most cases, smaller graft, we prefer to use a corneal incision. Now there's a dictum here, never ever touch the graft. It should be the host cornea where we have to make the incision. At any cost, do not touch the graft. Graft is always weaker. Number two, if at and in case of large grafts, ectatic grafts, then it's better to go with a scleral incision. Now, what is the advantage in using a scleral incision? Most of us want to leave this patient sutureless. A scleral incision, confidently you can go and leave this patient sutureless. In case of any corneal incisions, because the biomechanics is greatly altered in a post-PK patient, even if it looks normal on the table, it's always best to put a single suture and close it. So remember, corneal incision, always suture it, scleral incision, you can leave it just like that. Corneal endothelial protection, all of us are familiar with the soft shell technique, in the back phaco, low phaco settings and slow motion. And this is one reason why as soon as we see the cataract, it's better to plan and finish off this cataract surgery. The minute it becomes harder, it's going to create more problems to the endothelium. I have a short video. I'll try to, it's a long video, I'll try to run through the video actually. AQ. छोड़ो, directly play कर देंगे. VLC player नहीं है इसमें. Sorry, I was not able to use my computer. This computer is not playing the video. Yes. Why is it being tried? You can make one mark being made. This is at 90-degree axis. Now we have planned a toric IOL in this case, soft cataract, all sutures removed, has been quite stable for quite some time. And this cataract was noticed long back, younger patient, so big advantage. So we have planned a toric IOL. I'll rush through the videos, wherever important I'll just say. Go ahead, plan the toric IOL, mark the axis. Here we have planned a superior incision. Why did we choose a superior incision? If you notice this is an eccentric graft, less host corneal tissue here, more here, safer to go through this zone, so we can still manage with a corneal incision. The markings are made and then the surgery is started. Surgery, as regards the procedure, it looks as good as a normal phacoemulsification that we are doing. The smaller incisions, 2.2, definitely fare better. That's what has been done in this case. If you notice, the incision is completely on the host side, not on the graft side. And the soft cell technique, and then rexis. Rexis should be of adequate size. More important here, this graft itself will guide us regarding the size of the rexis. No need to do any kind of markings. Go ahead with that. And a normal phacoemulsification. Young patient, I think these capsules are very elastic, so using a rexis forceps to finish the surgery, and then finally finish off with a phacoemulsification. It was a very soft cataract, could not split it, so it was sort of do it somehow technique. Tried to chop it, but it was not possible, so finally decided to resort to do it somehow technique, and then suck the entire cataract out. But everything was done within the bag luckily, and then the lens inserted. I'll just take probably 30 seconds, that's all. I'm in the last part of the lens is inserted. This is a very important step. In case of post-PK or post-transplant, entire viscoelastic material has to be removed. These patients are more prone not only to glaucoma but also to inflammation, and that may lead to rejections. So entire viscoelastic is removed, and then the wound sutured, and later this was under injectable anesthesia. Patient was not very cooperative. And finally, the peribulbar injection was, the antibiotic and steroid injection subconjunctival was given. Now, regarding the post-operative medications, which I did not talk about, unlike the normal cataract surgery where we use short course of steroid, 4, 3, 2, 1 is what we are using, and many of us are using only 15 days steroids, but here we need long-term steroids, and on the first 1 week to have intense steroids. That is, normally we start with 2 hourly or 8 times a day, and after 3 days reduce it 5, 6 times, and then go to 4, 3, 2, 1. This is something that has to be done, and after the surgery for at least 6 months, 1 drop of steroid either on every day or on alternate days have to be used. So, any other questions? I'll be happy to answer.
I think due to paucity of time, we will take question later on.
Okay, sir. Okay.
So that was excellent presentation, Ellen. Now I'm going to invite Dr. Satyajit Sinha, who will be actually covering for Dr. Vibhuti Prasad Sinha, who could not make it. He would be talking on phaco in post in trabeculectomy eyes. You all know he's a very popular person. He is a member ARC East Zone and chairman scientific committee of Bihar Ophthalmological Society also. So he's going to talk on this important topic.
I'd like to thank Dr. Subhash Prasad, sir, for giving me this opportunity. And most of all, I should thank first all of you. Food is right there. It's lunchtime. And your dedication and absolute commitment to good ophthalmology is holding you here. So thank you for bearing with us during this lunchtime. Today I'll be talking about phacoemulsification in patients who have already undergone trabeculectomy. And remember, these are patients who have already compromised vision. They have an expectation, no matter how much you tell them, they have an expectation that one day when my cataract surgery is done, my vision will absolutely become all right and I'll be fine. And we are not able to reach that expectation, and that is where everything falls apart. We want to make sure that we don't make things matter worse by some complication in the surgery, so on and so forth. So what are the pitfalls in this? One, it's a challenging proposition for any surgeon, because whatever little vision is remaining, you don't want that patient to be devoid of that. Glaucoma requires... Glaucoma requires lifelong management. The development of cataract is a significant concern because its treatment may lead to loss of intraocular pressure. The visual field is also an issue when there is advanced cataract, and most bleb failure occurs soon after cataract surgery. Now, trabeculectomy significantly increases the risk of cataract formation. This has been taught to us for many years now. Major risk factors for cataract formation are complicated post-operative course following the filtering procedure, flat anterior chamber, post-operative inflammation. And as we all know, one study says that there's an increased risk of cataract formation by 14% post-trabeculectomy. So what are the confounding factors? Low corneal endothelial count, poor pupillary dilatation, atrophy and floppy iris, shallow AC, hypotony, pre-existing zonular weakness, extra caution to prevent posterior capsule rupture and vitreous loss, post-operative uveitis, post-operative bleb failure, and post-operative enhanced need for anti-glaucoma medication. So all those things contribute. There are several factors associated which leads to increased risk of loss of IOP, which are eyes with high IOP, younger patients, intraoperative iris manipulation, early IOP spike of more than 25 millimeter of mercury, posterior capsule rupture with vitreous loss, which is one thing we have to take care that it doesn't happen, otherwise it makes things even more worse. Interval between trabeculectomy and cataract surgery of less than 6 months. And through the presentation, I'll show you of how studies have shown that the gap should be there of more than 3 to 6 months. Now, pre-operatively, it is very important when you are taking up these patients to evaluate the bleb function. From before, you have to do proper IOP measurement. A good gonioscopy is very important, and you have to be very careful when you're doing gonioscopy in patients who have a bleb. extent of the optic nerve damage, and corneal endothelial cell count with specular biomicroscopy is very, very important because there may be compromised endothelial cell count. Corneal topography is very important. Assessment of pupillary dilatation is important. Evaluation of the type of cataract and lens density is important. In eyes with advanced cataract where fundus evaluation and fields are not possible, in these patients, B scan is very important to rule out gross retinal abnormalities such as RD, so on and so forth. Rule out zonular weakness and pseudoexfoliation. In preparation for these patients, intraoperative measures for preparation, ideally topical anesthesia if you could do, but if you are not confident, go ahead and give a block, and there's no need to be bringing anything in between and doing a topical. You can give block and do it, but make sure that you are not giving a retrobulbar anesthesia. Incision, clear corneal incision should be away from the side of trabeculectomy. Paracentesis port has to be away from the bleb. To counter pupillary miosis, injection of high molecular weight viscoelastic or stripping of the pupillary membrane may be performed when required. Dye during the capsulorhexis if you require, depending upon the grade of the nucleus and the red glow. The staining of conjunctiva overlying bleb through sclerostomy ostium intraoperatively, assessment of the bleb function is important. It helps in making the rhexis. Irrigating fluid, chilled BSS plus used will help to protect the endothelium also. When you're doing the hydroid dissection in these cases, in a compromised corneal endothelium should be protected by high molecular viscoelastics. Nuclear management, if there's a shallow anterior chamber, so the height of infusion bottle should be increased. Vacuum settings should be kept on the lower side in these patients. Phacoemulsification should be performed in the capsular bag to as far as possible, and use standard stop and chop or phaco-chop nucleotomy methods. Cortical aspiration through the cortical cleanup to avoid inflammation, thorough cortical cleanup to avoid inflammation resulting in bleb failure at a later date. When you're inserting the IUL also, you have to be very careful that it's in the bag. Square edge, single piece, foldable, hydroacrylic, intraocular IUL is best. Monofocal aspheric IULs have gained popularity. In case of a PCR, sulcus fixation of multi-piece hydrophobic acrylic IUL can be done. A thorough viscoelastic removal is mandatory. Bleb function must be assessed by injecting BSS, which we all do at the end of trabeculectomy. An internal revision of the performed by passing a cyclodialysis spatula through the wound or paracentesis port to the sclerotomy fistula and then to the subtenon space. Gentle arcuate movements under the scleral flap may re-establish bleb function. Suture applied to watertight closure of phacoemulsification incision if you are not very confident that the wound has closed properly. Subconjunctival injection of 5-FU may be given, or mitomycin C may be given if there is a chance of bleb failure. Now this is a video, as all the speakers have acknowledged,
patient of glaucoma with advanced
video
glaucoma
of being
and
from Dr.
operated
Subhash
lab
Prasad. I also do
needs
the
special
same.
attention.
And in this we will be
The
seeing
important keys are
the
to prevent damage to
surgery
the functioning blade, to prevent damage to already
post-trabeculectomy.
compromised ganglion cell, and to prevent late bleb scarring. High intraocular pressure during the
this is the
surgery
video
can
of,
actually damage the remaining ganglion cell, ultimately leading to the
pictorial
optic atrophy.
representation.
And not only that, the increased hydrostatic pressure
So as we said
sometimes
earlier,
can
you have to keep
cause
the parameters
the
low.
blade to give
so that
away
there's less
and
stress.
cause bursting of the blade, leading to blade leak. Presenting a video
So
of
this is a case of a 65-year-old
a known
gentleman
case of glaucoma
who had open-angle glaucoma and who had trabeculectomy
presented with
4 years
grade 2
back.
nuclear sclerosis
You can
with
see there's a
thin-walled
grade 4
cystic
cataract. The
bleb,
bleb is
disc,
well
OCT
formed.
and perimeter
This is the
showing
picture of
advanced
the optic
damage.
nerve head, and this is the picture of the OCT and RNFL.
One can damage the blade during
Now,
the
even
insertion
when
of
you are
the
putting the
So it's
speculum,
always
you
better
have to be
apply it
very,
under
very
the
careful that you
microscope,
do not
and
hurt
surgeons
the
should
bleb.
do
This is
himself
one of the
rather
things
than
you
ask
must
the
do
assistant to put
yourself
it.
Otherwise, in all routine cases,
just to
your
demonstrate that the
assistant
bleb
puts
is
the
not
speculum
leaking at this point
and
of
makes
time.
the
I am
next
doing the
case
serial
ready for
case
you. But in
using
the
the
patients
patent
who have
route.
had trab, make sure
I
that
made
you are
two
putting the speculum
paracentesis
yourself.
incision and one main port
This is the
2.2
serial test
millimeter
which is being
incision.
done to make sure
And
that the
I'm going to do
bleb is not leaking.
Jepto-assisted capsulorhexis in this patient. Before that, I
And a
formed the
leptorhexis
chamber
is
with
being
good
made
quality
to make sure
viscoelastic.
that the rexis is
And after
absolutely
suction,
circular.
energy is delivered to get
You could go ahead and
round
make your own
central
rexis with a
capsulorhexis.
routine cystotome also.
And once it is made,
This is not an
the
absolute
handpiece is
requirement.
withdrawn from the anterior chamber. Hydrodissection is
Then
being done
you have
here.
to be very careful when you're
and
doing
to
the
ensure that the
hydrodissection,
nucleus is rotating
and you
freely
have to
inside
make
the
sure that the
bag.
nucleus is rotating
With the
before you
gravity
start
fed
the
phaco system,
phacoemulsification
one has
surgery.
to keep the bottle height so high that
Now, the bottle height
the
versus
intraocular
IOP
pressure
in this
may
will
rise
be
up to
fit-
75 millimeter of mercury. But here
the video.
I will
Now,
do the phacoemulsification using the active fluidics of
the surgery
Centurion
has
vision
been
system,
initiated.
which can be done even with the pressure of 30 millimeter of mercury, which is very safe in this type of patient. And with this
Now
much
see,
of the
you
pressure,
have
the
to be
chamber is
very
very
careful.
stable
Whatever
and I am
phaco is
able
happening,
to
that everybody
crack the
is
nucleus in two halves,
acquainted with. But
and then
see
we'll
the
rotate
distance from the
and
bleb of the
make it complete
paracentesis and
two halves
of
so
the
that
main incision. That
further
is what is
chopping is
most
made
important to
easier.
see in this.
And once
Otherwise,
the
we
nuclear
are all
pieces
doing
are chopped in
phacoemulsification.
multiple pieces,
So you have to be
will
away from the
consumed
bleb so
one
that
by
you
one.
don't hurt
This
the bleb
intraocular pressure
at
of
any
30
point of
millimeter
time.
mercury is equivalent to the bottle height of 43 centimeters.
Is there a way to move this forward? No. Okay.
It is always advisable to inject viscoelastic through the site. It is mandatory to remove every bit of
As I
cortex
said, it's
so
very
that
important
there is
to
no
clean
chance
the
of any
cortical
inflammation
matter.
later on,
Because if there is any
which is so
remnant cortical
essential
matter,
to prevent
there will be
early
a
bleb scarring.
reaction, increase in
Inadequate
IOP,
removal
so on
of
and so forth,
cortex
and make things
can
more
cause
complicated.
rise in intraocular pressure also. That there are less chances of wound leak once I remove the irrigation.
Even when you are putting these
aspiration
intraocular lenses, you have to be very careful.
I am trying
As
to
Dr.
remove
Subhash was saying, that
all
you should
the
not tear the posterior
viscoelastic
capsule.
from the anterior chamber
Any
and will
complication
do so
in a
behind the lens
patient who has
also,
undergone
because
trap
retained viscoelastics are
will
known to
cause
cause
a lot of
early rise in
disasters. You have
intraocular
to make
pressure,
sure
which is
that
again detrimental
absolutely
to
a
these
perfect
compromised
surgery is
optic
done
nerve,
and no
and
viscoelastic
can
should
also
be left
cause
behind the IOL as we
inflammation
do
or
routinely
increase
in
in
all the cases,
inflammation,
but
which
in
is
this
again
case,
not
we have to
required
make sure
for
that no
bleb safety.
viscoelastic is left
Checking
even a
again the
little
bleb
bit. And
function,
once
whether
again,
it
it's
is leaking or
important
not.
to do
You
this
can
little
see
test
that
to
with
see
serial test
that the bleb
it is not leaking. That means the bleb
and
has
that
not
your
been
surgery is
injured.
successful. Now, post-operative considerations, you have to do a close monitoring of this patient. You have to monitor the IOP spikes and visual fields. You have to watch out for early signs of bleb failure. And if that is happening, you have to take the help of 5-FU and mitomycin C. You have to vigorously use topical steroids to overcome inflammation. Early detection of corkscrew vessels and encapsulation are signs of imminent scar formation, and subconjunctival 5-FU can be given in such cases. Now, I was saying, if you see in this study, in the second column, you can see the time between the trab and cataract surgery, the months. So when the time period is more than 3 months, the success rate is the highest of being 86%. So you should give this time more. The time between the trab and the cataract surgery that you're doing should be more than 3 months. So the last slide, delay the pearls which you have to remember. Take-home messages are: you should delay the cataract surgery until the bleb has matured, at least for 6 months. Assess the bleb function before surgery. Evaluate pupillary dilatation. Minimize conjunctival trauma. Utilize a small clear corneal incision as far from the bleb. Assess bleb function upon completion of cataract surgery and revise if needed. And aggressively treat post-operative inflammation and IOP spikes. Thank you so much for your patient hearing.
Thank you, Dr. Satyajit. And now we'll hear the chief instructor himself, Dr. Subhash Prasad, a prolific cataract and IVR surgeon. He's a member of the managing committee of AIOS right now. And in every conference, you'll see him running from hall to hall delivering his presentations.
I just first like to thank Dr. Satyajit for covering the topic which was supposed to be taken over by Dr. Vibhuti, but he could not make it. And today morning he actually took this video because he was not prepared. So thank you very much. So this is the last talk of this session, the phaco in operated VRIs. This is again a challenging situation for anyone. We all know that the cataract is a very frequent complication of any vitreous surgery, and nowadays large number of vitrectomy are being performed. And with advancement in the technology in vitrectomy also, the surgical results are very good, but at the same time cataracts are also increasing incidence. So prevalence can be up to 80% of the vitrectomy cases, and the risk factors are if there is any intraoperative lens touch, even if it is not there, if you have injected silicone oil, use of intraocular gas, and older patients or post-operative uveitis, these patients do end up with cataract early and early. In children, the most of the time it is posterior subcapsular in nature, but in adults it is nuclear type of cataract, which is more frequently encountered. So what are the challenges in these patients? Most of the time, the most important I would enumerate is that they have low endothelial cell count. There is high chances of deep anterior chamber, which may have silicone oil without silicone oil bubbles. The journals are compromised. People often don't dilate that much. The scattered sometimes may be very hard, and a lot of these patients have PC plaque or some opacities on the capsules, posterior capsules, that cannot be removed, and reduced visual potential in these patients. So there are several pre-operative, intra and post-operative considerations that has to be taken into account for successful outcome. And like in any case, detailed patient history, the nature of the surgery which the patient underwent, whether the patient having injected silicone oil, or whether it was a gas, or whether the cataract progressed very fast, just to rule out any posterior lens capsule touch. Pre-operative examination, particularly to look for posterior capsular tear or jonular dehiscence. And whenever possible, it is always mandatory to do the indirect ophthalmoscopy, not just to see the cataract, but to prognosticate the patient, because you may have associated retinal detachment, recurrent retinal detachment, which can be missed. So patient may expect that after surgery everything will be all right, but patient won't improve, and then patient will blame you. So that is very important. B scan if the cataract is very advanced. So biometry is not an issue if there is no silicone oil in situ, but if there is silicone oil inside, then the biometry axial length actually gets changed. So you have to take into consideration that factor also. So the thing is that if there is 1300 centistock of silicone oil which has been implanted, nowadays most of the VR surgeons, they actually paste a sticker about the silicone oil, so that can actually guide the next surgeon what was the silicone oil used. So you can multiply it with the conversion factor of 0.71, the axial length, which is multiplied, and that gives the almost nearly accurate axial length measurement. So here, unlike in LASIK, where the cornea was making the problem, here the axial length is making the problem in the biometric calculation. So if the patient is going for cataract surgery with silicone oil removal, then the planning, maybe the IOL power calculation may be different as compared to when the patient you still want to have the silicone oil in situ. So these patients require little bit of adjustment, but most important thing is that these patients must be consulted beforehand, that postoperative outcome may not be very accurate, and you may require some adjustment of the IOL power, maybe even sometimes even exchange or piggybacks. This is just one example of the latest generation machine, the optical biometer IOL Master 700, which fairly gives accurate calculation of the axial length, provided the cataract is not that much dense. You can bang on the post-op refractive error of this was a patient who had post-operative refractive outcome of minus 0.25 cylinder spherical only. So using the latest machines also helps in some situations. What the other problems which we encounter is during surgery, that is the problem with the anesthesia. So most of the patients must be given NSAID and cycloplegic even longer before what we give in the routine cataract surgery, so that there is no intraoperative meiosis during the surgery. Topical anesthesia but intracameral lidocaine is suggested because there is sudden deepening of the chamber that can cause some discomfort to the patient. And whenever you anticipate that the surgery will last longer, you give a peribulbar injection and sometimes GA also. So the problem in the surgery is that these patients have hypotony most of the time, so use copious OVD, very deep anterior chamber. So if you are using the gravity fed system, keep the bottle head low, but at the same time you have to take into the consideration that if you are keeping the bottle head low, use the slow motion phaco, like low infusion, low smaller lower parameters, and keep the microscope zoom little low. Corneal incision should be 2 to 3 steps. for small people, you should be ready with your hooks and rings because you may require it, and standby VR surgeon is always mandatory. It's not mandatory, but always preferable. So doing capsular access in these patients may be difficult because most of the time these patients do have anterior capsular fibrosis. So just using cystotome may not help you. Sometimes you have to use Vanna seizure, and if you have the access to vitreous cutter, this vitrectomy cutter probe actually very useful in these patients where you can cut the anterior capsule, make a small opening of around 5 millimeter in the central anterior capsule, and then go ahead with the phaco. Use the dye always because the glow will not be that much good as in the normal cases, and with hydrodissection you should be very gentle because many patients they have weak posterior capsules. Phaco is always preferable over SICS, and always follow the dictum of slow phaco. Rule of thumb is that avoid applying excessive force on the lens during emulsification. Avoid reverse pupillary block and infusion deviation syndrome, and whenever possible, if you have access to the active fluidic system, that gives better outcome or better you can say the comfort during the surgery. The cortical aspiration should be bimanual because there may be a sticky cortex just below the anterior capsule at many places, so bimanual IA is preferable. IOL placement should be very gentle, and the choice of IOL should be hydrophobic or hydrophilic, or you can use the PMMA also, but silicone IOL should not be used. Large optic IOL should be used with 360-degree square edges, and plate haptics and silicone IOLs must not be used. This is a small video clip of a patient who had undergone VR surgery, and now silicone oil, even in the anterior chamber, it has come as emulsified silicone oil. So just doing the cataract surgery in this patient, just to demonstrate that these patients may have silicone oil in the anterior chamber, that also creates some problem in biometry and visualization, and corneal endothelium gets compromised. So just to show that I am demonstrating this case. But phaco, again, like in any myopic patient, whatever precautions you observe, you should observe here. I will move to the next video because of paucity of time. This is a case who have undergone vitrectomy previously. You can see the port scar here, both sides. And as soon as I enter the anterior chamber, you can see that the iris, the whole lens iris diagram shifts posteriorly. This is called actually lens iris diagram posterior shifting of the lens iris diagram. That is also called reverse pupillary block. For that, you have to relieve that. You can use iris spatula below the iris, and then this will be relieved, and so the phaco will become easier. Otherwise, everything will be so deep that it won't be possible to approach the lens correctly and do the phaco correctly in these patients. I will skip this video. Just wanted to show low IOP phaco, how useful it is in these patients. This was a operated case of vitrectomy. Since there is no posterior vitreous support, so lens always try to go down, and the chamber becomes excessively deep. So using this active fluidics technology of keeping the IOP of 20 millimeter actually does not cause any fluctuation in the atrial chamber. So that is very, very actually useful and very safe. Just small video clip showing the posterior capsular plaque in these patients. After removing the nucleus and the cortex, you can see there is thick posterior capsular plaque which is not going as such, but I am trying to remove it with the Sinski, and you can very well do it some of the some of the cases. You have to just create a cleavage, and then with the use of the forceps you can take it out. But even after that, there is some opacity of the posterior capsule, so that can happen very regularly in these types of cataract. Just another 1 minute video of pre-existing PC tear in the patients who have undergone vitreous surgery. I actually landed up with the problem of there was since pre-existing rent, so the part of that thing actually went down into the vitreous cavity itself, and then before coming out if you have a PC tear in any situation, come out before coming out with the cutter with the IA, you have to inject viscoelastic through the side port. Post-operative care is again more aggressive because there may be more inflammation. There are increased chances of posterior synechia, secondary glaucoma, and CME. So there is need of increased and rigorous follow-up in these patients, sometimes even lifelong, like in diabetic patients. So these some of the patient you can see posterior synechia, again silicon wall. So just to summarize, you have to plan these patients in advance, do proper biometry if silicon lesion in situ, have a standby gadgets available like sulcus, IOL, CTR, hooks and rings, and you do slow motion phaco to avoid any complications, and these patients need regular and long-term follow-up. Thank you very much.
Thank you, Dr. Subhash, and thank you all for sitting through the session during lunch. The next team, you can ask the questions, and the next team come over.